Merci de contribuer ainsi à ce rayonnement. C'est grâce à vous et également aux conférenciers et conférencières que ces activités de transfert des connaissances sont un succès. L'intérêt pour ce type d'événement est bien présent et nous incite évidemment à poursuivre nos efforts en ce sens. Ces conférences sont rendues possibles grâce à l'appui du CIUS de l'Ouest de l'île de Montréal, de nos centres de recherche, donc le centre de recherche de l'hôpital Douglas, le centre de recherche de l'hôpital St. Mary's et de la direction des affaires académiques et innovation, ainsi que de l'unité de transfert des connaissances SynapTiC. Je tiens également à remercier toutes les personnes qui ont participé, de près ou de loin, à la réalisation et à la mise en œuvre de cette conférence. La conférence d'aujourd'hui aura pour titre Anxiété et troubles neurocognitifs majeurs, explorer les approches non pharmacologiques dans la gestion des comportements. Pour cette conférence, nous avons l'honneur de recevoir Mme Megan Williams, donc travailleuse sociale au CIUS de l'Ouest de l'île de Montréal. Mme Williams travaille depuis plus de 18 ans avec des personnes atteintes d'un trouble neurocognitif majeur et leurs familles. Après avoir obtenu sa maîtrise en travail social à l'Université McGill en 2008, elle a travaillé dans le secteur communautaire en tant que conseillère et plus tard comme directrice des services de soutien au sein du groupe Alzheimer situé à Montréal. Au fil des ans, elle a encadré des familles et des professionnels de la santé et a obtenu une certification de coach et de formatrice auprès de Dee Pasneau, une experte américaine reconnue en soins aux personnes atteintes de démence. Depuis 1 an et demi, Megan fait partie de l'équipe spécialisée en symptômes comportementaux psychologiques de la démence du CIUS de l'Ouest de l'île de Montréal, où elle élabore des plans d'intervention non pharmacologiques personnalisés pour les personnes atteintes de troubles neurocognitifs majeurs afin d'améliorer leur qualité de vie et celle de leur entourage. Donc, cette conférence sera tenue en anglais. Donc, sans plus tarder, je passe la parole à notre conférencière, Megan. Donc, merci, Mme Williams. On vous écoute. Merci beaucoup.
Merci beaucoup, Sylvain, pour l'introduction. Thank you, everyone, for being here today. Obviously, this is a very important topic that hopefully is pertinent to your work, professional life, or personal life. So today we are going to talk about anxiety and major neurocognitive disorder. As Sylvain said, that I work part of the CIUS BPSD team. Now, I just wanted to explain that today I'm going to be using major neurocognitive disorder and the term dementia back and forth. We are talking about BPSDs, which is, again, behavioral and psychological symptoms of dementia, otherwise known as responsive behaviors, challenging behaviors, expressions of unmet needs. So to begin, I just wanted to give you kind of a context. There's an estimated of 75% of people living at home and up to 80% of people living in a long-term care facility who exhibits at least one BPSD. So that would be either anxiety, agitation, depression, apathy. And BPSDs are in advanced dementia tend to be more agitation, irritability, disinhibition. So as a social worker on the BPSD team, my job is to really work with my colleagues, assess the risk to the client and to others around them, as well as to then develop non-pharmacological plans to reduce the frequency and the intensity of the behavior. Today, we are going to focus specifically on anxiety, but some of the content that could be applied to other BPSDs as well. So today, just again, some of the objectives is to better understand how anxiety manifests in people with a major neurocognitive disorder. So what's the difference between a major or minor neurocognitive disorder? It's really where there's a decrease in mental functioning and a loss of the ability to perform a day-to-day tasks, so otherwise known as the older term dementia. So today we're going to understand how it manifests, look at some of the factors that might contribute to the behavior, as well as at the end explore some of the possible non-pharmacological interventions that we can use to hopefully improve the quality of life of the person and those around them. So I wanted to talk just to present a case study today. Hopefully, we'll have time to look at interventions that we can do with this client. Again, it's a fictional client, Mrs. White. She's 81 years old. She lives at home with her husband of 57 years, Colin. They have 3 children together, one of whom died in a car accident 20 years ago. She was diagnosed with Alzheimer's 5 years ago. Stay-at-home mom, worked in the schools as a receptionist and a volunteer coordinator for 20 years. She's always been great with people, kind, attentive to their needs. She was always a social person. She would host gatherings at home, invite friends over, go to the church twice a week, regular outings to the community centers where she would hang with her friends. But again, family was always her priority. She would rearrange her schedule whenever possible, and dinners were very important for her. So now fast forward, Colin, her husband, volunteers 3 times a week and leaves his wife home alone. During this time, she'll do laundry, she'll watch TV, she'll speak on the phone with her daughter. But over the last year, the husband's noticing that when she's being more and more anxious when he gets home, and she has these episodes of verbal aggression towards him, and things can escalate rather quickly. So I understand this is a case in the home setting, but it just shows to you how a person's cognitive impairment, what they once were able to do that they enjoyed very much, is becoming more and more difficult for Mrs. White, and things need to change once there's a diagnosis. So now just for this first section, we're going to talk a little bit about anxiety and major neurocognitive disorder. So, what is anxiety? Just to be clear, it's an unpleasant feeling caused by fear of the thought that something is bad is going to happen. So, it's an anticipation of threat or that uneasy feeling. It can also cause physical changes, such as, heart palpitations, loss of appetite, stomach problems, running to the bathroom, muscle tension. So anxiety can affect our ability to remember and our ability to think clearly and to concentrate. So think of long ago when, we had exams to study for. You were well prepared for your exam, but on the day of the exam, you became extremely anxious and all of a sudden you lost all that information. So imagine thinking of someone with dementia who already has a cognitive impairment, already has difficulty with gaps of information lost, and they are anxious. We're talking also today about older adults specifically. Consider the life changes that they go through. They're going through retirement, perhaps physical decline, loss of friends or their social circle, loss of the meaning, worrying about finances, not able to doing the same things that they once loved to do. So it's no wonder why older adults become anxious. You might see people all of a sudden avoiding social settings, calling their children frequently, needing reassurance. And these are people who don't even have dementia. 30 to 70% of people experiencing major neurocognitive disorder have anxiety symptoms. Okay. It tends to be more frequently where the person might have some insight to their diagnosis, because not everyone does, or people in the earlier stages, fear of what's going to come, the progression of the disease. Maybe a parent of them or a sibling of theirs has or had dementia and they don't want to and have the progression transpire the same way that it happened for them. So just a question for everyone, if you can maybe write in the chat, and Marie-Ève can help me. Someone who has a major neurocognitive disorder who is anxious, what does that look like? What have you seen?
Certainement. Donc, on a asking the same question over and over.
Right.
We've got increased cognitive malfunction, comportement d'agitation. So they get
Yep.
more agitated, impatient, more confused. They are looking always for the same object. They say that they have gastrointestinal symptoms.
Right.
So errance and patience, they could crie et cou, they get scared.
Right.
So that's
Okay. Parfait.
yep.
That's the list. That's a great list. Obviously, you know, people have seen it. So just I kind of summarized it and made it simplified. But of course, there's more symptoms than's described here. Repetitive questions. When is dinner? I need to go home. People become insecure and irritable. Shadowing and clinging to a care partner. Oh, this we see often where whether it's a professional or a family member, they won't leave their sight. It could be where, you know, the care partner has to actually hide in the bathroom just to get a few minutes by themselves, and then they're still at that time knocking on the door. Pacing, agitated, restless, going back and forth in the hallway, not knowing really what to do with themselves. Hoarding objects sometimes because they're so afraid of losing them. And then what happens is that there's so many objects or so many materials that they actually misplace an item. And of course, wanting to go home. I should have put that in quotations, but for many people, home is not necessarily the, you know, it's more of a sense of security and safety. People think it's their home long ago with their parents and so forth. So these again are some of the symptoms, and it's really to when does it pose a risk? It's when there's a risk to themselves or to others. So if anxiety becomes to a point where the person's not eating or not sleeping well, that's a big challenge, especially if they become really agitated. You know, if of course, with a more advanced major neurocognitive disorder, you'll see more sundowning, vocalization, repeated cries for help that you can see. Um, So I just wanted to quickly explain what's happening with the brain. So as you can see from the center, there's the amygdala in green. So the amygdala is essentially a structure within the brain that responds to sounds, sights, taste, smells, anything, and it essentially reacts to protect you from danger. So it evokes a fear response. So typically the prefrontal cortex there that you see, the frontal lobe will calm the amygdala down with logic, reasoning, evaluation. But with a person with dementia, their brain is dying. It's progressive, and anxiety and feelings of threat are triggered more easily. So they're trying to make sense of the gaps of information that they can't access. Also, impairment for people with dementia would be the front of their brain, their frontal lobes. So, as much as the amygdala, the fear center is really trying to hijack the brain from the surroundings that they observe, the frontal lobe can't regulate emotion as it should and is unable to override it with a rational response. So what you tend to see is people go in the three major categories, that fight, flight, or freeze mode. So freeze, they're terrified as to what's going to happen, but they can't move their bodies. The flight, where you see people needing to leave, you know, quote unquote, the word escape, but they need to get away from danger. And then the fight mode, where they have to defend themselves from the perceived danger. So essentially, anxiety can be the base of this, but it can definitely escalate rapidly. Sometimes I hear people saying it was just like a switch that happens, that the person goes from irritable and then there's some verbal aggression. So if a person is feeling agitated, they're tapping their fingers, they're making repetitive movements, it can quickly escalate. And we need to pay attention to their verbal and their physical body language to see how we can respond to these behaviors to hopefully avoid any verbal or even physical aggression. The impact that anxiety has is huge on the person living with dementia and their care partners. They're distressed, both of them. They have a reduced quality of life. They might be so anxious where they can't go out in social settings, in activity programs, dinners with their family. And so essentially the two of them, the couple, they become isolated, which might lead to premature institutionalization, over medication, lots of caregiver guilt that we see. Caregivers don't know how to necessarily respond, and they get exhausted, and they might yell, they might repeat themselves, and then they become impatient. The relationship changes, and there's also some grief that's associated with that. And of course, if anxiety happens in the evening and at night, there's a lot of poor sleep habits. So interventions based on recall don't necessarily work. Oops, I'm sorry. They don't necessarily work. I'll be right there in 5 minutes. I'll there and help you. And we need to look closer at the behavior and have a toolkit of different interventions to further support them. So to investigate this behavior, I strongly believe in a person-centered approach, understanding the person, their history of life, ask family the questions and give them context as to why you want this personal information. Who is this person before you actually see the behavior? What are their culture, what their preferences, their likes, dislikes? And you really need to treat the person's past as if it was their present. So the more you know who the person was, the better you can kind of be that investigator. So what is the context? These are how you gather the information. So how long has the behavior been happening? Did it start suddenly? We want to rule out delirium. How often is it happening? Is it when it's a different care partner? What is the risk? Is it getting worse, the behavior? Is it intensifying? Also, what's the degree of stress and burnout possible for the care partners? So talking to the family members and care providers and getting a full picture is really important, as well as understanding what interventions were tried. Because I've seen many times where one care partner will try, or a professional will try something, and they don't necessarily relay the same information to the rest of their team. So how do we actually assess for anxiety with people living with dementia? There is one scale that by far outweighs the others specifically for this population. It was actually a recommendation number 50 for the Canadian Coalition Seniors Mental Health Report. You can see that in the references. So it's the RAID scale, and essentially it's some people use the NPI or the geriatric anxiety inventory, but this one is high, shows the most evidence. So basically, there's a scale. So you would look at the person, if they can answer. If not, you'd ask the care partners, and you would evaluate between 0 would be there's no behavior, 1 would be mild, 2 moderate, and 3 severe. So the symptoms should be based on the last 2 weeks. And also a score 11 or more would suggest that there is clinical anxiety. So factors that contribute to anxiety, the physical and emotional state, the environment, and of course the psychosocial interactions. So we know that the brain changes, their ability to comprehend, to remember, especially the recent short-term facts, their ability to concentrate, to be attentive, their judgment is off. They can't express their opinion the same way. It causes them a lot of distress, not understanding what's happening, worrying about a situation from the past or a person from the past as well. So I'm just going to go through quickly some of the factors and then we'll go through some of the interventions. So some of the physical factors that you might look out for, what be causing the anxiety. I put pain here because with any BPSD, you want to assess, is the person in pain? Can that be treated to avoid any discomfort? Of course, acute infections such as UTIs are predominant with people living with dementia, and you want to rule any possible infection out. New medication can have counterintuitive reactions, so a full workup on their medication with a nurse or the geriatrician is vital. Looking at their medical history, so someone who might have a history of depression or anxiety, were they treated in the past? What was the medication and what was the results of that is really important to know if you have that information. And any unmet physical needs. So you want to see, is there something that you can do for the person to decrease their distress? You know, as a person has the progression of the disease, they have a more narrow vision. So they might interpret things differently. They might not have their glasses. They might not have batteries in their hearing aids. They might not know where the bathroom is, or the fact that they have this urge to go to the bathroom and not know what to do with that. So looking at the physical factors are important. Now, the emotional factors, these are just a list of some of the emotional needs of someone. Need to feel safe and secure, connected to others, feeling competent, accepted, a sense of control, a sense of themselves, sense of purpose. They're all really important things that tend to go when you have cognitive impairment. So it's really important to understand the meaning behind the anxiety and ways that we can respond to these emotional needs. So looking at just the environment, if you can go in the chat very quickly and look at this image and see what are some factors that could trigger a person's anxiety. Now keep in mind the person might have or has a major neurocognitive disorder. What are some things that you see?
We have désorganisation, constant white noise from the TV, clutter, luminosity, stuff on the floor and on the table, possibility of hitting an object because of the clutter, no light.
Yep. Yeah, and I mean, the list can go on and on. You know, there are many people that, you know, without dementia, this room could create a lot of anxiety, but it's how they're perceiving the information. So going back to the amygdala and what they're making sense, there could be sirens going off it looks like maybe the window could be open here. You know, really TV could be like kind of on static, not being able to find the object that they want. It can cause a lot of distress, feeling that they're not doing a good job in their job because there's glasses and dishes that are out, and oh my goodness, what's happening? Or where's my family? Where's my, who's going to help support me? So this environment in this photo can trigger a lot of anxiety in someone with dementia. So just very quickly, obviously this is a more peaceful picture, but daily routine. Could the person be upset? Maybe they've moved to a new residence. The routine is very different. Their care partner could also be away on vacation. Their children are looking after them and aren't following the regiment, breakfast, watching some news, going for a walk. So that can cause a lot of anxiety in someone. Sometimes actually caregivers don't have a routine because they're just exhausted, or maybe they weren't the person who used to always have routine. They were kind of the fly by the seat of the pants. But you have to adapt because they thrive on a routine and knowing what's happening next. Also in the environment, what do they see? What do they do? How they touch, how they misperceive threats. There's lots of different ways that the environment can cause, as we talked about, can cause some distress. And finally, the task. Is it, if it's someone asked to do a task that's too complex or too hard, doesn't make sense to them at all, they can get really anxious because, they're afraid of failing. So that's really important that we have to pay attention to. Am I asking too much of them? Do they even understand what I'm doing? Psychosocial factors. So this is more that would cause anxiety, more the in terms of your interactions with a person. So a poor approach. We talked about best approaches with people, with how to approach someone. So perhaps the person's tone of voice, their body language, they startle them from the side, and again, the vision loss, they don't see them. You're touching the person without permission. I've seen that a lot. The person needs time to process information, and you're going too quickly because you have to go to the next resident. Communicating in very complex sentences. I'm speaking very quickly today, and I can guarantee you a client would not be able to follow what I'm saying. Another thing would be caregiver stress and anxiety. This is vital. So what you see is, you might not see it in the moment, but if you think back as to, was I stressed today at work? Was I stressed when I was interacting with my loved one at home? Because our body language, when you're stressed, you might look rigid the way that you position your body. You might not realize you're taking it out, or that person is sees that you're stressed and might not understand. So, if I'm walking around like this because I'm angry, as to my family, what happened in the morning before I got to work, well, this body stance is really intimidating for someone with cognitive impairment. And, you might not even realize that you're doing it. So, also, you might be fearful of going to see a resident who might be verbally aggressive, and you might be really tense and scared, and they can feel your body language. So really pay attention to, maybe your anxiety or your stress is causing stress in them. Unrealistic expectations, you're asking them to do something, again, that they can't do, and they're stressed about it. Using distraction without acknowledging the personal state. So I hear this often, okay, well, I'm just going to I'll give them a cookie. Hopefully that will ease their anxiety. Here you go, here, have a cookie, or here, go watch this, go read this. But at the end of the day, if you're not acknowledging their emotion, their fear, their stress, their distress, it's really, you're not going to get anywhere, and they're going to get more and more anxious as time goes on. I'm just paying attention to the time. Okay. So with interventions, it's really important to understand the person, and in order to not have the anxiety escalate into this fight, flight, or freeze mode. You want to make sure that any intervention is targeted to address the underlying factor and not necessarily the behavior directly. So when you're looking at interventions, you don't just look at the physical, the environment, and the psychosocial. You might have to look at all three and make adjustments as is. Care plans are extremely important, making sure that whatever intervention you do is personalized and meaningful to them, and that is you're going to take a strengths-based perspective. So you're going to, what can the person still do, and what residual abilities do they still have to feel confident, as well as to maintain safety. So I really like this quote, beneath every behavior is a feeling, beneath every feeling is a need. And when we meet that need, rather than focusing on the behavior, we need to begin to deal with the cause and not the symptom. So it's really important to understand that you might not always know what they need, but over time, the more you know the resident or you know your person, the more you'll connect with them and hopefully figure this out. So as I said, that our team takes a non-pharmacological approach, but I did want to address a pharmacological approach. Medication is not always effective for certain BPSD behaviors. Examples are sundowning, wandering, apathy, and so forth. But for anxiety, there are some medical treatments that you could try. Medication should only be considered when the non-pharmacological approach has been tried and it's not working. Medication should not necessarily be given indefinitely. Attempts to stop or to reduce the treatment should be made over time. Antidepressants have been known to correct the imbalance of chemicals in the brain that contributes to anxieties. So that would be something like Celexa. I hear often that sometimes people are given benzodiazepines, which are more antipsychotics, and they respond to a short-term relief of anxiety, but they're not supposed to be used in the long term because of side effects. It's extremely addictive and so forth. So again, make sure that you're having someone to review the medication. So now we're going to go into the physical interventions that are quite basic, but it's important just to kind of assess before going into other alternative interventions. So you need to ensure that the aids are functioning. Glasses, not only do they have them, but are they clean very often, or are they theirs? Sometimes they might be using another resident's glasses. Batteries for the hearing aids, have they been adjusted? Is it the right do they even have their hearing aids? Do they know how to put them on, or do they need assistance? Limit the person's coffee intake, of course. Any of you who are addicted to coffee, you can definitely get feeling a little bit more agitated, which can enhance your anxiety. Ensure your physical needs are met. So sometimes people are really anxious because they don't know where the bathroom is, or they're afraid of having an accident. They've had too much intake of liquids. They're not able to express themselves. So it's really important to make sure their needs are met. Do they need more sleep? When you're anxious and you're not sleeping at night, you tend to be more disoriented, which can make you, again, more anxious. So sleep is vital for people living with dementia, as well as physical contact. So we talked about the emotional needs. So just giving a person a hug holding their hand will give them that feeling of affection and the feeling of security. Of course, again, as I said before, you want to ask permission before you touch a person. You can do that just by putting your hand out, and very often you'll see them that automatic response, and they'll shake the person's hand. So many people with major neurocognitive disorder do not get enough affection. Some of the environmental interventions, we would create a calm environment. This would sometimes make sure that they're in a quiet, a safe place. Sometimes there's too much commotion. So if you have a quiet corner, and soothing rituals, maybe that's where they read their newspaper, if they can still do a Sudoku. It just needs to be a calm environment away from maybe the kitchen, or if it's at the family, loud noises. Maintain, as I said, a daily routine with flexibility, because as you know, things can change. And if a caregiver is extremely rigid, or a care partner rigid with the routine, and it's just not a good day, again, it can show in your tone of voice and your body language. It's going to make the person more anxious. So be flexible when need to be. Modify the environment depending on the time of day. So sundowning creates a lot of anxiety. The brains are tired, tend to be more disoriented. So you might want to close the blinds, make sure there's adequate lighting, again, and have that, do an activity that's meaningful to them. Use signs to orient the person. If the person can't find their room and they don't know where their belongings are, sometimes you think about like LED lights to put around their doorway so they know to go into their room that way. They might need arrows down the hall because it's a long hall and every door looks the same. They might not recognize a recent picture of themselves, and they'd recognize a picture of them long ago. So you have to adapt the environment in that way. Break down complex tasks into smaller steps. Might be too overwhelming for them, and again, sense of failure. And then opportunities for meaningful activities. Okay. It's a really important philosophy. The person's doing the best that they can, and they can adapt their behavior. And you must reflect as a care partner, reassure and adapt your approach. You can't control the person at all. You have to teach yourself how to reduce anxiety, in whatever way that means. So, social interactions. Using a calm approach. Pay attention again to your body language. Again, you might create that anxiety. Simplify your words, sentences. Offer choices to let them feel in control. Complement them with your words with cues. So if they're having trouble with the comprehension and they're in a state of anxiety, they're not going to necessarily listen to your words, but they're going to see your actions and your gestures. Give them time, slow down to complete a task or even to respond. Listen. You want to enter their reality, which I'll talk about in a few minutes. Provide reassurance that things will be okay. I know you want to go home right now. Home is really important to you. You're safe with me. Give them positive feedback and praise. It can go a long way. And sometimes I want to say that sometimes you need to substitute the care partner. Sometimes you're just having a bad day and you need someone else to tag in. And that's okay too, because in the long run, you're going to be helping the resident. Okay. Responding through to anxiety through validation. This is a really important skill. You want to step into their reality. Naomi Fell was, she coined the validation therapy, and it's really understanding the person's perspective. So you're focusing here on the feelings and not necessarily the facts of what they're telling you. So you're diving deeper and putting on their kind of glasses to see how they're seeing the world. You're providing reassurance, and essentially you're building a trust, a sense of security, and not necessarily telling them that what they're seeing is wrong. You need to be with them where they're at. So if they're saying, I want to go home, you say, home is really important to you. They want to go home because of that security factor. And even if they can't go home, or you can say, I know we can't go home right now, but because I'm still working here, but could you spend time with me, because we always have a good time when we're together. Okay. So alternative interventions, one of the biggest and most important intervention for people with anxiety is music. Music, it can be a tool to reduce agitation, which again is a symptom of anxiety. There's essentially 3 ways that you can do this, and I'm not a music therapist, and you don't necessarily need to be to reduce their anxiety. So singing is really important. I'm sure many people that you interact with love to sing. It reduces endorphins into the brain, and it has evidence where it boosts your mood, improves their sense of well-being, and really alleviates that stress and anxiety, as well as it promotes a trust and bond between the individuals. Another thing that's really great with music is that you can listen to music together, have a playlist, ask the families what their favorite music is. I do want to say though, if a person is really agitated and all of a sudden you play relaxing music, that might agitate them more. Sometimes you need to kind of bring the music down gradually. So to transit into calmer sounds, and doing that, you're slowly working with them and not necessarily bringing them to that that calm state. I also want to say that a person who's angry has a right to be angry, and if you listen and validate them, maybe they need to start with a louder piece of music and again bring them down. Playing instruments. Now, this is a lot of people say, oh, I'm just going to get some instruments. We'll have a little music session. Playing instruments might increase their agitation. And so again, certain instruments are quieter than others. If it's a guitar and they're used to playing, then that might calm them. I'm aware of the time. We have to go a little quicker. Creative intervention, so doing some art, it develops positive coping, self-esteem. Some people are anxious when it comes to art or looking at a paintbrush. They feel like they're going to fail, but it's really about the process and not the product. So one technique could be third hand facilitation, where essentially you're going to draw or color and you ask the person to pick which color you're going to use if you're coloring a mandala. Make sure that if they are participating in art, that it's material, it's adult-like. Adult images are really important that you can get on the internet. And you can also have art discussions about paintings. Even commenting about some paintings around the room might decrease that anxiety. Reminiscence. There's a lot of good evidence that reminiscence will decrease anxiety. It allows a person to speak about what they remember. So again, a strengths-based perspective. Conversations about the past, images, objects, using music, videos. Beware of trauma. So this is why life history is so important. Make sure that you're not going to start reminiscing on a traumatic event, like with Miss White, the event of the car crash. You're not therapists, so that's really important to get that knowledge first. Physical interventions, dance, physical exercise. Make sure these interventions are adapted based on their needs. It can decrease depression and anxiety in older adults. It can help with sleep problems. And it can be leisure sports. It can be chair exercises. Just getting fresh air and going for a short walk can be great for them. Pet interactions favors trust, calm, concentration, decreases anxiety. Beware though, if you bring your animal to work or to someone's house, the person might hold the animal too tightly, not let it go. So has to be the right context. Sometimes giving them the toy to throw the toy will eliminate them holding on the animal too tight. There's also, this is a picture of a robotic cat, which I've seen actually decrease anxiety, people in residences. Sensory interventions. Here we have weighted blankets. This is a hug doll that there's studies in UK. It's a doll that has like a heartbeat inside. It has weighted arms. Again, that connection, that affection. Aromatherapy, I put it up here, but there's very little evidence that that actually helps to decrease any anxiety. People talk about snoozling rooms. Again, it can also, those types of rooms, you need lots of equipment, and it could actually make a person more restless. So you have to see each person is very different. Okay, I'm not sure if we're going to have time to talk about other interventions to try, but you can put them in the comments list, comment section, and I'd love to hear about them because there are many. And I just, the case of Mrs. White, you can kind of go through what might be important to her. You know, her environment, she's home alone. She doesn't have a lot of cues maybe. She doesn't have a daily routine because her husband is out 3 times a week. Maybe we need to limit her alone time, hire a companion. Her husband definitely probably needs to validate her feelings more, understand, you know, that if the laundry wasn't done properly, she's doing the best she can given her cognitive impairment. She might benefit from reminiscence, the music, and the art interventions. I think really in this case, so having purposeful activities because she was so social, outgoing, she loved to connect with others, volunteering, maybe with a buddy at church where it's a familiar environment to her, so she can feel helpful, productive, but also be social. So those are just some of the suggestions. And very quickly, my last slide, I'm sorry for going so quickly, but recommendations to investigate, reduce, and to see which interventions to do for people with anxiety. So enter their reality, investigate the risk factors, triggers, frequency, and intensity. What are the person's unmet needs? What is the anxiety saying to you? What are they saying? What's their body language telling you? Who is this person? What's her life history like? Families might be a little bit resistant to giving you detailed because they might feel as though you're intrusive and it might not be necessary. But if you take the time to explain how you're going to use this information, you'll see that they will likely open up and share important facts. Make changes gradually, one intervention at a time. If you do it all at once, you don't know what's working and what's not. Communicate your plan or the plan with other people on your team. Make sure you might want to document and have a log to say what's working. Was she more anxious in the evening? You know, suddenly, was there a change? And again, just learn about the disease, get creative, get flexible. There's a really good document about overall good practice, the Canadian Coalition for Seniors in Mental Health. There was a report put out in 2024 this year that also has a lot of different recommendations, not only for anxiety, but other BPSDs. So. I think I might be over my time. Sorry, Marie-Ève.
No problem. Donc, ça a été extrêmement apprécié. On va